Hello everybody, this is Dylan. I wanted to reach out to you to share some kind of innovations I was working on, thinking about how we can best move our research group forward. So one thing I've been thinking about lately is this concept of being able to have some educational components, which are so many in research, compared to, say, professional development committee or quality or other committees where there's just not the same amount of education that surrounds learning prior to us actually implementing and being involved in projects. So this is pretty common among all research groups. So there's that component. The other one is actually operationalizing. So once you get some of these skills that we can build and we can mentor together, not only among our group, but to each other and each other on the unit, once we get a little better at it, is to actually do it and be more involved in projects and that type of thing. So my goal today was to sift through a lot of the Johns Hopkins tools we use here at Freightert. Particularly, we use the Johns Hopkins EBP tool, but there's also lots of other great tools. So I created this little document that you see here, this Johns Hopkins tool for safety and quality projects. I just titled it that because I want to begin by doing these educational videos that maybe can give our group a boost, where we can learn about some of these concepts in sort of different ways to kind of break up the paradigm of just the meeting and kind of the chaos that can be at meetings where it's difficult to get to them even when you have the ability to do them at home. So my thought is asynchrony is helpful with quite a few of us from just my experience talking to a lot of you, where you can do and be maybe more active with learning some of these concepts when it's convenient for you. So I've begun to compile some of these resources. There's quite a few of them here today, but two that I found were really useful was this tool here called the SPIRIT tool, which stands for Safety Project Inception, Readiness, and Implementation Training, which is quite a mouthful, I know, but it's a toolkit. And what you'll find with doing these types of research projects, evidence-based practice, and quality project is that tools really guide our thinking, that we don't really go into these projects willy-nilly and kind of halfway thinking of an idea. They all start with brainstorming, but really this is to funnel those brainstorming sessions into a pretty rigorous framework so that we can really tease out some of the questions, the clinical questions that are relevant so that we can do things that really impact patient safety and quality always. And also involve us and engage us as caregivers, which is the best thing about the research program that I love this work. So looking at this website, here's a link that you can follow to get to it. Underneath, the second one is a podcast I found from the Johns Hopkins Center for Nursing Inquiry, which is absolutely phenomenal. It's two nurses. One is a coordinator for research. The other is a coordinator for evidence-based practice. And they both talk very openly and conversationally about just every topic that you can imagine in research and quality improvement and safety projects. So I found this recently and I'm just blown away by the quality of it and how good it is. Specifically, I found one today to talk about briefly about the three forms of inquiry. I touched on this during our last two meetings kind of briefly, but these concepts stem from what the heck is quality improvement, what is evidence-based practice, and what is research. And although when you look at it in their own domains, it's pretty clear, but when you just jump into projects and be involved, there's a lot of gray area where there's a lot of potential for confusion. So it's just nice to start in a stepwise fashion where I'd like to go over what is quality improvement, and what then a step up from that is evidence-based practice, And a step up from that, evidence-based practice would be like, what is a research project? So, looking through some of these other items, here is the Spirit Toolkit. So this is a page where it's from the Armstrong Institute for Patient Safety and Quality. And like I said, that link that I gave you in that document takes you here. And this is just a phenomenal way of getting the tools in your hands, in our hands, in the Research Council, to begin to really look at a systematic, tool-driven way that basically is error-proof if you follow it appropriately when you're looking at a project and understanding it. So I'm not going to drill too deeply into all of these, but I would just like you to know some of the things. So looking at this first one, the differences and similarities between patient safety and quality improvement, I thought was really good. So I think that is up here somewhere. Yes, it's this screen. And this document, once you open it, is really differentiating and drawing our attention to when we talk about safety and then we talk about quality, what is what. So the Agency for Healthcare Research and Quality is absolutely critical, federally based organization that actually funded Johns Hopkins study that I'm going to talk about later called CUSP, C-U-S-P, or the Comprehensive Unit-Based Safety Program, which is pretty cool. But looking specifically at this, the 6 aspects of quality care came from the Institute of Medicine's groundbreaking report in 1999, To Err is Human, examining how medical errors are a huge portion of deaths annually in healthcare. And it really shocked the nation and a lot of the providers because of that basic fact, how much death occurs because of errors and human factors. So they found through their groundbreaking research these 6 domains. Obviously, safety is the number one, but this article here, which is really good, it kind of differentiates and says, okay, we get that there's safety. We don't want to harm our patients ever. We want to prevent any harm, or if we do have harm, we want to make it as little as possible. But it goes down these other items as quality items. So was, like number 2, was care effective? Number 3, was it patient-centered? And was it timely? Was the care efficient? And was it equitable? Was it fair, essentially? So there's a great many items in this document that are really good, but I really want to draw your attention to this point here. Some of the similarities of all these 6 basic aspects from that IOM study. Try to eliminate finger pointing and blaming individuals. Absolutely. This is very critical in how we approach any type of conflict or problem in the unit or in our life, honestly. Also, removing and preventing workarounds that fix problems temporarily. So nurses are renowned for this. We're problem solvers. We're always at the bedside. We have to figure it out when there's some kind of a problem. But clearly, we're trying to remove those workarounds by standardizing approaches because evidence shows that that's the safest outcomes for our patients and ourselves. So not to belabor this document too much, it's really good. Again, I just wanted to kind of touch. So when we talk about safety, what kind of outcomes do safety outcomes produce? Well, they look at reducing infections, reducing falls, stuff we've all heard about before, because we're measured by them, by the Joint Commission, reducing medication errors, and I like this increased reporting of near misses. So all of these things are excellent domains we could look at for safety. Now looking at quality underneath that. So what do we mean by that? Well, we could look at, in the domain of effectiveness, how didn't we follow an evidence-based practice protocol that maybe we should have followed? Or how did we follow it and that reduced the risk? What about waste? How many times a day are we noticing waste? Are we mindful of waste? What can we do to notice it and then do something about it? Also, going down the line here, you can see other issues to do with access, improving access of care. Also, reducing time from order to delivery would be timeliness. So one of the main questions, and I'll move on from this document, I ask all of you guys in research is, why did you want to do this in the first place? And the reason I ask that is because evidence shows that if we're able to really dig into the purpose as to why we do what we do, we can really establish some engagement that's intrinsic, that basically builds off of itself, because you actually want to do these things not like because of a carrot and stick model, but because it actually aligns with the reason you get out of bed every day. So what's in it for you? For some of us, it could be just to satisfy a grad requirement, totally understandable, a school project, I get that. Some of us want to gain research experience, which is awesome. That's incredibly important in elevating the nurse profession. Some of us see this as a potential career pathway and want to get better and become more skilled at it, which we all will do in this committee. Also, we can do this because we want to do something impactful to move outcome to help patients. That's another win-win situation. You get better at a skill, you feel empowered, you also help a patient. You can do things that even affect whole systems. And finally, the last one I really like is just the satisfaction of knowing you're doing the right thing for your patients. So moving along, there's a podcast I found that I think is awesome. So particularly the 3 forms of inquiry as denoted here by this title. I have it kind of forwarded to this snippet where these 2 nurses are talking about what is research, what is EBP, and what is quality improvement, because that's where I'd like us to start and understand. Just going to play a few seconds of it here, but to listen to the whole 13 minutes is ideal, and there's so many more I'd like to explore from this as we go along. So here we go.
Search. Are there tools for these types of inquiry?
Of course there are. So for quality improvement, we have what's called an A3, which is a document that sort of helps you walk through all the parts of your project. So you have it mapped out from the very beginning. You know what your problem is, you know what the goal is, and you have a timeline to help move you through. And that's a quality improvement tool that we use here at Hopkins. And that also sometimes will walk you through the PDSA cycle, which is the Plan, Do, Study, Act, which is also a well-known quality improvement strategy.
So a little snippet. It really is great. It's a totally legit, solid source of information coming from these 2 leaders in nursing evidence-based practice research. And also it's done in this conversational mode, which is, I am hoping will reach us and get us a little, so the information is not so dry, and we can kind of check out these podcasts on our own and bring that to the table. So moving along, I wanted to show a little bit about the Agency for Healthcare Quality and Research, or I should say Research and Quality. So it's a very good website where a lot of these are based on these quality improvement projects and so on. But it seems like I'm having a little difficulty bringing up this page for whatever reason. So that's okay. I can go to another page that I was interested in sharing with you guys, all from the Spirit Toolkit. So if I go here, this A3 template that those guys were talking about in their podcast there, just briefly they mentioned it, is available right here. I just wanted to share that with you guys as well. So there's the 5 whys, which is another really great thing. And then there's this differences and similarities, which I've kind of shared. But the Learning from Defects tool. So this is another really great tool I thought was helpful. And this tool is the CUSP tool that I mentioned earlier, the Comprehensive Unit-Based Safety Program, that AHRQ, whom I was trying to open up over here, and let's see if they'll let me. Great. So now it's going to let me open it. So let's check out this video. So this is the Agency for Healthcare Research and Quality. Awesome, super great federally funded website, all about evidence-based practice, research, safety. This is specifically talking about the CUSP toolkit. So this agency funded Johns Hopkins study of developing this CUSP toolkit to make your unit safe. So let me just see if I can play a section here, or if it will or won't let me. It may not let me. I had it.
Nurse who also has an MBA
This is
in
the part I
health
wanted to share
administration.
with you guys.
And I'm a nurse manager of an OB unit currently. My entire 35-year career has been in maternal child health. One of the tools that you use is the staff safety assessment, and the staff safety assessment gives you an overview of what your department's issues are. From nurse-physician interaction, it reviews how the nurses feel and look at the department. It reviews how physicians feel and look at the department. It talks about communication issues. It talks about how safe the staff feels. Do they feel like they're understaffed? Do they feel like they're tired? That there may be a safety event looming in the future. It really gives you an overview of your unit needs. The relationship between physician and nurses is vitally important for safety of the team. And I think it's something that really needs to be worked on. When you're looking at safety issues, you have to empower every member of the team to be able to speak up. You really have to have situations where physicians and nurses can get together. You want the physician in CUSP to really understand how to communicate well with the team. We try to do some team building exercises. We try to do that every 6 months. And we allow them to get together and have some open dialogue. What are the issues? What concerns do physicians have? What concerns do nurses have? How can we bridge that? And allow them to hear each other, so that if they're able to hear each other, then when they're in a situation that's critical, then they will be able to communicate better. You want the physician.
So I think this is great because so many reasons, but there is research that shows that the more you communicate, the higher quality of communication you have. So just to touch on what she was saying, really so much hinges on communication, and it's all part of this unit-based safety program that we can dig into later. So quickly, before I wrap up, I wanted to show you this CUSP tool area called Learning from Defects. It defines what a defect is. Even it go. Of course, we know the typical offenders: surgical site infections, VTEs, missing equipment, but I really like this one: nursing spend time away from the bedside. So they define it essentially as anything that can lead to preventable harm. So that's all great. It explains how the tool can help. You look at it from a system level. The solutions you create are likely to be lasting ones. So it really looks at human factors and how a system influences the individual, not totally eliminating the individual's accountability, but recognizing that if we really want to make a lasting change, it has to be something that we drill down systematically. 4 basic questions. So this document is incredibly cool because it's interactive, and I'll scroll down to it below. But it asks these 4 basic questions. So what happened when there is an issue with a defect? Why did it happen? How will you reduce the risk of it happening again? And how do you know that the reduced risk happened? So you got to be able to measure it somehow. It also goes through this section about your assumptions, and here who should be using it. Everyone on the unit, including physicians, nurses, HUCs, EVS folks. I mean, critical care techs, crucial in that front line, being in the rooms often, seeing things that maybe even nurses aren't seeing. So just a great collaborative philosophy involved with rolling out these tools. So we can ask question 1, and it goes down: who was involved, what actions occurred, and what were they thinking, these members of the team that were involved? And are there benefits or rewards because of these actions, or were there some perceived pain points? So this gets to the idea of maybe looking at these character building moments as challenges, but as able to reward for doing an action after recognizing maybe a misstep in our care occurred. How can we improve this constantly, and how can we tie that into making both growing our research council as people that people can come to on the unit to ask for help, to mentor them through projects, and to do it in a systematic way, but also to ultimately provide for the best safety of the patient. So I wanted to quick, because I'm taking up quite a bit of time here, show you this really cool document. So when they analyze why did it happen, they have this great contributing factors section where it says, okay, what was happening with the family? What was happening with the patient? And it has this interactive scale where you can actually click on and interact with these check marks that say, whatever the factor is in the left-hand side in the gray box, did whatever factor increase harm or did it decrease harm? Did it increase risk or decrease risk? And then this gives us great data points to analyze when trying to form a clinical question. This one has examples built in, but also you can type in. I'll show you. You can kind of just start typing and creating your own, which I think is great. Was there a language barrier? Was the patient agitated? Was another example. So going down the line here, what about task factors? Was there a protocol that we did or didn't follow? Well, that's huge. And that is something that we should absolutely analyze. And then you can type in what other task-based factors were happening. What about caregivers? Was a caregiver tired? Very crucial in understanding maybe why an error or a safety event happened. And then going down the line to what about the team? How was communication with the team? Was it clear? Was it concise? Did we use standardized tools like SBAR? This really helps us get objective about addressing problems. Knowledge and skills factor. Did anyone find the protocol confusing on the team? Well, that's definitely going to inhibit the functioning of a knowledge base for the team and how critical it is for those links on the chain of care to be strong. So if someone is not really familiar with how to go about certain processes, that's going to be a problem. And there's technology factors, which are also really critical. And finally, without spending too much time, what about the local environment? This, I thought, was a great example. A nurse was caring for more patients than usual because another nurse went home sick. Well, that happens all the time, but sometimes that data gets anecdotally captured in retelling of a safety issue or a conflict staff might be having. But if you use this tool, it really starts to get at some of those and tease out some of those details that sometimes get overlooked. So that's really all I have on that. I don't want to belabor the point too much. I wanted to show you guys some of these things that I was looking at. I'm hoping you enjoyed this a little, and I can't wait to hear some of your feedback, and I appreciate the time spent listening to this. And it's my hope that if you like these, I can produce more of these and start providing tools in this way so asynchronously we can watch these, we can learn on our own, and we can bring and elevate our own personal accountability and bring these concepts, sharpen our skills to the table at our meetings and be able to kind of enlist some of the skills that we build and then synergize and be stronger as a group because of it. So thank you very much. I appreciate your time.